In this section, we will take an overview about the quinolone group of antibiotics. The first in the group was nalidixic acid. It had a narrow spectrum, and then came fluoroquinolones, the prototype of which is ciprofloxacin. What it did was it extended the spectrum, and now we had cover of both Pseudomonas and Staphylococcus aureus. And then came the respiratory fluoroquinolones because they had more predictable activity against Streptococcus pneumoniae and could be used as empirical therapy for community acquired pneumonia. The agents are levofloxacin, ofloxacin, and moxifloxacin, and we have agents specifically designed for MRSA, which are dilafloxacin and levonorifloxacin, which is a molecule which has come from India. They are available in oral formulation, IV formulation, and also for topical application. The problem with quinolones has been resistance, and it has been seen that whenever the GNBs have ESBL, they also have co-resistance to the quinolones, and the carbophenamases elaborating organisms also have the same phenomena. The major reason for resistance is employment of the efflux pumps and binding site abnormalities. Now, if you look at the mechanism of quinolones, they work on the DNA gyrase and DNA topoisomerase, and depending on which is inhibited more, some specificity might be there for a particular organism. And spectrum, as we had talked, has both gram positive, gram negative, anaerobic and atypical coverage. And because of this atypical coverage, a quinolone can be used as a monotherapy in community acquired pneumonia. What about the usage in current practice for respiratory infections, gastrointestinal infection, genitourinary infections, skin and soft tissue infection, bone and joint disease, typhoid, anthrax, sexually transmitted diseases, prostatitis, which is interesting because the quinolones have excellent penetration in the prostatic tissues. There are very few antibiotics to choose for prostatitis, and also they have activity against mycobacteria. And oral quinolone levofloxacin is actually advocated as a part of the MDR-TB regimen. The problem with quinolones has been the adverse events, and the major concerns are tendinitis and tendon rupture, neurotoxicity, hypo and hyperglycemia, and QT prolongation. And because of these, especially in the elderly, we may look for an alternative agent for upper respiratory tract infections and uncomplicated urinary tract infection, where there are lots of safer agents to choose from. So where we are left to use it? Well, as per the IDSA guideline, the respiratory fluoroquinolones can be used as monotherapy even for severe pneumonia, for complicated UTI, drug-resistant TB, skin and soft tissue infection, MRSA infection, and for anthrax. Majority of the quinolones are metabolized in the liver and excreted via the kidney and would require some amount of dose modification in the presence of renal dysfunction. Moxifloxacin is unique because it has biliary excretion, and also it has a greater anaerobic coverage compared to other quinolones. So quinolones will always have a place in therapy in the intensive care, and probably one place where they find greatest application now is in management of pneumonia and for MRSA infections.